Cervicogenic headache (CEH) and occipital neuralgia (ON) are two types of headaches that originate from the neck and the back of the head. Both conditions can cause significant discomfort, often radiating from the occipital region to the top of the head. Due to the close relationship between the structures in the upper cervical spine and the occiput, their symptoms can overlap, making diagnosis challenging. Patients may experience unilateral or bilateral pain, sometimes accompanied by tenderness or pressure points in the neck. Understanding the similarities and differences between CEH and ON is crucial for effective diagnosis and treatment, as both conditions require a tailored approach based on the underlying causes and patient history. Prevalence of cervicogenic headache varies widely, ranging from 4.1% to 20% depending on the population studied. Occipital neuralgia is less common, with an incidence of about 3.2%. ON tends to peak between the ages of 60 and 69 and is slightly more common in women. Both conditions can be idiopathic or result from trauma, nerve compression, or degenerative changes. Understanding who is most at risk helps clinicians focus their diagnostic efforts and tailor treatment plans to the needs of specific patient groups. Recognizing these demographic patterns is a key step in the clinical approach to headache management. Cervicogenic headache typically presents as a unilateral non-throbbing pain that starts in the neck or occipital area and spreads to the front of the head. The pain can last from hours to days and is often aggravated by neck movement. Occipital neuralgia, on the other hand, is characterized by sharp stabbing or shooting pain in the distribution of the greater, lesser, or third occipital nerves. Patients may also report sensory disturbances such as dysesthesia or tenderness over the affected nerves. Both conditions can sometimes mimic migraines or other headache types, making careful clinical evaluation essential. Diagnosing cervicogenic headache relies on criteria established by the International Headache Society and Sjosted et al. Key features include evidence of a cervical disorder, headache onset related to neck pathology, and improvement with treatment of the cervical issue. Physical examination may reveal limited neck movement and tenderness over specific cervical structures. A diagnostic nerve block can help confirm the diagnosis. It's important to distinguish CEH from primary headache disorders, as treatment strategies differ significantly. Accurate diagnosis ensures that patients receive the most appropriate and effective care. Occipital neuralgia is diagnosed based on the International Headache Society's criteria, which include recurrent, severe paroxysmal pain in the distribution of the occipital nerves, often accompanied by tenderness, dysesthesia, or trigger points. Pain is typically relieved by local anesthetic block of the affected nerve. Imaging may be used to rule out other causes, but the diagnosis is primarily clinical. Recognizing the characteristic features of ON helps differentiate it from other headache types and guides the selection of targeted treatments. Thorough physical examination is essential for diagnosing both CEH and ON. For CEH, clinicians assess neck range of motion, palpate facet joints, and identify tender areas or pressure points. For ON, examination focuses on sensory changes such as allodynia or dysesthesia in the scalp, as well as tenderness along the occipital nerves. These findings, combined with patient history, help pinpoint the source of pain and guide further diagnostic steps. Physical examination remains a cornerstone of headache evaluation, ensuring that subtle clinical clues are not overlooked. Distinguishing CEH and ON from other headache disorders is crucial. Conditions such as migraine, tension-type headache, cluster headache, hemicrania continua, and medication overuse headache can present with overlapping symptoms. Key differentiators include the location and character of pain, response to neck movement, and associated symptoms like nausea or photophobia. Excluding serious underlying conditions such as tumors or cervical spine pathology is also important. A careful differential diagnosis ensures that patients receive the correct treatment and avoid unnecessary interventions. Imaging studies such as cervical X-rays, CT scans, or MRI may be used to rule out structural abnormalities or red flags in patients with CEH or ON. However, the correlation between imaging findings and pain is often modest, and many degenerative changes are seen in asymptomatic individuals. Ultrasound is increasingly used to identify nerve entrapment or guide injection. While imaging can be helpful in select cases, the diagnosis of CEH and ON remains primarily clinical, supported by targeted tests when necessary. First line of treatment for both CEH and ON is conservative management. This includes patient education, self-care strategies, analgesic medications, and physical therapy aimed at reducing muscle tension and improving posture. Transcutaneous electrical nerve stimulation, TENS, is another non-invasive option that has shown benefit in clinical studies. Most patients will have tried some form of conservative therapy before seeking specialized care. Optimizing these treatments can help many patients avoid more invasive procedures. When conservative measures are insufficient, local injection treatments may be considered. These include nerve blocks with local anesthetics, sometimes combined with corticosteroids, targeting the greater or lesser occipital nerves or cervical facet joints. Injections can provide short-term pain relief and help confirm the diagnosis. However, repeated steroid use carries risks, and the duration of benefit is often limited. Careful patient selection and technique are essential to maximize benefits and minimize complications. Radiofrequency ablation, RFA, is an interventional procedure that uses heat to disrupt nerve function and reduce pain. For CEH, RFA of the cervical facet joints has shown benefit in some studies, with pain relief lasting up to a year in select patients. However, evidence is mixed and not all patients respond. RFA is generally reserved for those who have not improved with conservative or injection therapy. The procedure carries some risks, but serious complications are rare when performed by experienced clinicians. Pulsed radiofrequency (PRF) therapy is a newer technique that delivers electrical pulses to nerves without causing significant tissue damage. PRF is considered safer than conventional RFA, especially for neuropathic pain like ON. Studies suggest that PRF can provide longer-lasting pain relief for some patients, particularly when targeting the occipital nerves. While the exact mechanisms are still being studied, PRF is gaining popularity as a minimally invasive option for patients with refractory headaches. Occipital nerve stimulation (ONS) is an advanced treatment for patients with ON who do not respond to other therapies. This procedure involves implanting electrodes near the occipital nerves to deliver electrical impulses, modulating pain signals. ONS has been shown to provide significant pain relief in many patients with refractory ON, though it requires careful patient selection and carries risks such as lead migration or infection. ONS represents a promising option for those with severe, persistent symptoms. Surgery is considered a last resort for patients with CEH or ON who have not responded to less invasive treatments. Surgical procedures may include nerve decompression, neurectomy, or partial rhizotomy. While some patients experience significant pain relief, surgery carries higher risks, including infection, nerve injury, or persistent numbness. Careful consideration of the risks and benefits is essential before proceeding with surgical intervention. Most patients will benefit from exhausting conservative and interventional options first. In summary, the management of cervicogenic headache and occipital neuralgia requires a stepwise, evidence-based approach. Start with conservative treatments such as education, medication, and physical therapy. If these fail, consider targeted injections, radiofrequency procedures, or nerve stimulation. Surgery is reserved for the most refractory cases. Accurate diagnosis, patient-centered care, and ongoing research are key to improving outcomes for those suffering from these challenging headache disorders.